the Thank you for inviting me to do this. I consider it a great honor to be able to talk about a subject and a topic that is so dear to me, and to share it with people that, you know, some of you I know out there, some of you I don't know at all, but I just want you to know how important this work has been to me, and that I feel the years that I've had as a professional nurse working with substance use disorder is, you know, I look back on it and I just feel blessed. I don't know how else to describe it. Many years ago, I worked with a wonderful physician at Heartbeat Foundation who worked with the residents who came and spent a couple of months with us at that time to learn about addiction and about treatment. His name was Dr. Ralph Dunnigan, and many, many times I heard him say to those residents and to patients themselves is that what they really needed as they were withdrawing from drugs and alcohol was good parents. And he meant and said to them, Father Time and Mother Nature. And I still believe that that is very, very true, that people have no idea of the nature of what their bodies go through as a result of their substance use, and what it takes for their bodies to just kind of forgive that and to find a state that's normal again. For some people that is less than desirable because of the ravages of their addiction, but for many people, the human body finds itself to be very forgiving, and that they can return to a wellness state and can find joy in their recovery and good feelings, and a return to not just physical health, but emotional and mental stabilization too. So in this series, I feel very fortunate to be able to just talk about the beginning of that, and how people manage, and how we as professionals and people dedicated to trying to help people find their way to recovery, how we can help them understand withdrawal and what their body's going through, and how we can assist them in a way that makes this a process, not an event for them, but a process, and to help them understand that they're not going to feel better the day they stop using and when they stop using, but that we can help them know that there is light at the end of the tunnel, and that there is a place where they're going in their recovery that's going to be a lot better than where they're at in that acute phase. So I'm grateful for what I know, and I know what I know. I think because of the thousands of patients that I've had the privilege of working on, physicians worked with through the years, that are so much a part of the process of understanding how to look at this illness as illness, and to help people find a way to feel a lot better. So I'm grateful for what I knew back then. I'm grateful for really what I know today. And I'm looking forward to learning more today, tomorrow, and in the days to come. I still love the work I'm doing. I would still want to be able to share what I know with others to try to make a difference. So if you're new to this profession, or if you're a veteran like me, it's just such wonderful work. No matter what we do, or in what venue we're working in, we're making a difference in the lives of the people that need us the most. The tragic circumstances of the number of overdose deaths, and the overwhelming problems that we have with opioid-related issues now requires all of us, our finest efforts, our most supportive kind of care and understanding, not just of the patients themselves who are suffering from an opioid use disorder, but for their families and friends, and for those of us who work with them. So in the series that we're presenting, it's looking at non-pharmacological ways of looking at assisting people into their recovery and easing some of those physical and emotional and mental challenges that they're facing in recovery. So hopefully as we discuss this today, and I'd like you, if you have questions, to use the chat. I'd like to just go through the information that I have available, and then we'll certainly entertain any questions anybody has, any additions if they'd like to make, any comments they'd like to make, and become a part of this. I mean, that's my favorite part of these ECHO sessions is the questions and answers, and at the end, I think that's where we learn the most. So what is really withdrawal management? It truly is just whatever interventions that we can use that are aimed at managing the acute intoxication that people present with, or the withdrawal symptoms they experience as a result of their substance use and dependence on the substance that they are using. My experience with patients addicted to opioids and that group of drugs has always been the most challenging. Their withdrawal has been significant and long-lasting and very difficult in the post-acute phases of withdrawal. And I think that's so much of what the alternatives that we're going to talk about in these next sessions really aim at helping people managing those long-term kind of symptoms. But withdrawal management really just seeks to minimize the physical harm. And that's what we have to do first. We have to stabilize people and address the physical harm that those substances have brought to that human body. And withdrawal management, I found, and these are statements truly from lots of sources, but a lot from the ASAM criteria, is that we realize that withdrawal is a kind of illness and that it affects all areas of people's lives. But for many people, the reason they don't seek treatment, the reason they don't seek help is this particular acute problem and the symptoms that they know that they're going to have to deal with. So the process of withdrawal management consists of three components, where you evaluate somebody, you determine what level of care they really need as far as withdrawal management to stabilize them and to foster them then for a readiness into some kind of treatment services, whatever that may be, whatever journey that may be for that person, whatever they prefer. But we work in concert with the patient and their needs and their wants in a way that is very different than the way we used to approach treatment, where we had a program and people came to it. If they didn't fit, we showed them the road. And we didn't know any other way to do it. And now as we evolved, we do far better at individualizing treatment and meeting the needs of patients on an individual basis and developing a treatment plan that's theirs and theirs alone. So the management process that doesn't incorporate all of those critical components is truly incomplete for that patient and inadequate. And there's lots of ways to do this, but it should include all three of those aspects. We want to, know that and remember that withdrawal management services do not offer a cure for substance use disorders, and people still use that word. They still have that belief that they're going to go someplace and get fixed and everything will be okay. But this is just often their very first step, or the first door that they come through as they pass into a treatment program or into their recovery. But substance use disorders, we have to remember to tell people, are treatable, and that there is hope for recovery for every patient. There's sometimes a hopeless feeling that people have, especially people who have significant relapsing in their illness, and they have tried many different ways or many different paths to find recovery and are feeling hopeless themselves. Their families do, but we have to be the beacon of hope for people. We have to offer that to them. Substance use disorders are brain disorders, not a moral weakness. Patients should be treated with dignity and respect at all times, and especially at the times when they're feeling the least respectful towards others and the least dignified in their behavior is when they need us the most. So they should be treated non-judgmentally and in a very supportive manner. We need to remember those things. So when we plan services, we want to be do that in partnership with our patients, whether what their needs are, and really addressing what they want and starting at that level with them. And then we work with their social support network, including their family members, significant others, or employers that have, for many patients, been the impetus that got them into treatment services, or they came to work under the influence, or very sick, or had significant sick time, and their employers were the ones who really did the intervening to get them the help that they need. But all health professionals involved link the patient to appropriate substance abuse treatment services immediately after they're through that withdrawal management phase. We want to really include all of the people that are necessary to help move the patient into the support that they need in order to follow that path. So an integral part of that is making sure that we are using multiple disciplines to address all of the needs that we can for the patients in this acute phase. Active involvement of the family is often the most important support that there is for that patient. Many of them have worn them out, but many of them still retain hope and want to do what's necessary. But other support systems are really important as well. And tapping into those and discovering what they are and utilizing them for the patient's good is part of our job as well. But we need to remember to respect their right to privacy, and we have to ensure that we follow the federal guidelines for confidentiality too. So we have to keep those in mind as we involve others in the treatment of our patients. Patients should be treated with due consideration for their individuality, their backgrounds, their cultures, their preferences, their sexual orientation, disability, vulnerabilities, and probably the first thing I should have said is their strengths. And sometimes it's very difficult for them to see them. Sometimes it's really hard for us to see them as well, but they are there. I mean, you think of the lifestyle and the havoc that addiction has on people's lives, and you think that they're survivors of so much and so many things that we'll never comprehend or understand, and yet they have the strength to have come through that. They have to be reminded of that they are survivors of an illness that is overwhelming. These are the ASAM levels of care and patient placement. This is from the 3rd edition of what kind of services, how ill a person will be with withdrawal. In the 3rd edition, they're lined out wonderfully according to the substance of abuse. And you look at the risk factors very specifically related to those specific drugs of abuse, and then assess them based on how severe those symptoms are. You look at the kind of support system that's necessary, what kind of service delivery is necessary, what kind of staff is involved in each of the levels of care, and then what kind of assessment and treatment plan will be necessary, documentation standards, and discharge criteria. All of that's included in the information that's available in the placement criteria. And I have to say, this is the most sensible thing that I've seen in my work as an addiction nurse. It helps us think in the way that is best for our patients. Sometimes we get so caught up in their stories, in their history, in their presentation sometimes, in what we know of them from previous contact with them, in the relationship we might have with family or previous professionals who have worked with them as well, who have concerns about them. It can be a lot of things that affect us as we assess somebody. But what the criteria does is help us look at it, sit back and look at what the symptomology really is, and help them move them in that direction. Because our patients may not always realize just how significant their symptoms are, or where they can lead, or what kind of serious illness and problems might exist as a result of their withdrawal. And some of them might also really maximize what and have significant fear of what they're going to experience, and yet they can be managed with support and support services in a much lower level of care than people actually believe is necessary. So it falls to us as the assessors and the professionals to really look at their symptomology, at their current functioning and what is actually necessary. For many years, I think people believe that the only way that you could successfully detox a patient from alcohol and other drugs was to put them in an inpatient treatment program, in a detoxification unit, usually connected to a treatment program, or in a hospital-based setting. People were very afraid of what withdrawal was going to be like. And yet we know now that withdrawal can be managed very, very successfully in much lower levels of care, in outpatient programs, as long as there is monitoring and an ability, when we assess the patient, to move them up or down in those levels of care depending on what their needs are. And we might assess somebody and think, well, they really could benefit from a residential stay in a social setting detox, and they may stay a day or two or a couple of days, and they stabilize very well, and they can step back into outpatient services and continue treatment services at that level of care. Or many times people start in the lower levels of care and just require some basic on-site monitoring, but there will always be availability for more intensive services beyond what you begin with. And there's always should be ongoing support at a lower level of care than when you start out as. So the distinctions with these levels of care are from the lowest level of care, level 1, which is managed in a physician's office. And more I hear about the use of MAT in home induction, where a patient is assessed, can determine that they can successfully use buprenorphine in a home setting, take their first medications at home after they've filled them from a pharmacy, and are in contact on a regular supportive basis with the physician and the nursing staff or the other staff, the case managers who have a part in the care of them. But a home induction, when I first began using MAT with people, I couldn't even have visualized that. But more and more, because of the needs and the lack of services for people, that we've adapted and addressed the use of both pharmacological MAT medications in that circumstance, as well as non-pharmacological approaches to dealing with that. So these are the criteria I would really encourage you to look at the very specific levels of care, and look at the criteria that has been developed with great, I think, focus, and the undertaking to develop these levels of care is an ongoing kind of approach to understanding this illness and understanding the best ways to treat it. So I love the ASAM criteria. I love how it helps us as professionals focus and do our work. The domains generally in the biomedical area that you assess someone at to determine their level of care has to do with their general health history and what kind of major health problems they have that may really influence the level of care that they might need to withdraw successfully. What is their general mental status? Physical assessment with a neurological assessment is a part of that. The basic vital signs. You want to know their pattern of substance abuse. Do a urinalysis or a toxicology screen for commonly added substances, so you know what you're dealing with if it's more than one substance in the body of the patients they present. And look at their past substance abuse treatments and past withdrawal management they have. What is their history? We can sometimes predict what is going to face that patient, what challenges they'll face in their withdrawal if they've done this before and have been successfully managed in some way or another, or unsuccessfully managed in some ways. The psychosocial domains we look at too as part of that whole initial assessment is the demographic features. Where do they live? What are their circumstances? What are their living conditions? Who do they live with? That sort of thing. And also, are they at risk for violence, or what is their suicide risk? What kind of transportation issues do they have? And is that an issue? And for many people, you can offer the best services available, and they can't get from here to there in order to access the services that you're suggesting, or the support, or if you're doing an outpatient withdrawal management, getting them back in to see you again sometimes is a very difficult transition for people. So understanding that as well, and how that limits the kind of work that you can do. What is their financial situation, and can they, is there a way that you can help them, contact or get onto some kind of health care if they don't have that available to them, and to help them do that? How about in their home, are there dependent children that they're caring for that's really going to impact the involvement they can have? And legal status too, sometimes we have to consider that, if they're under if there's warrants, if they've had significant legal involvement recently, and that's an issue that's bringing them into treatment services or seeking help. And also physical, sensory, and cognitive disabilities, if there are any present, how we can adapt the treatment plan that we develop for withdrawal management based on those needs as well. Symptoms that just to remind ourselves of the kind of things that would require immediate medical attention in a much higher level of care generally is when patients that we're seeing in acute withdrawal have a significant change in their mental status, or they have increasing anxiety that is very difficult for them to manage, if they're hallucinating and out of touch with reality or delusional, if they present with healthcare problems, especially with infections in their body, and they should be considered infections with temperatures greater than 100.4. If there are significant increases or decreases in blood pressure or heart rate, if they have insomnia, significant abdominal pain, bleeding anywhere, changes in their responsiveness in their pupils, or in their responsiveness just into their general their general behavior and assessment. So also too, we need to address the possibility of suicidality with patients in acute withdrawal. They are in despair for many people, facing all kinds of problems on the outside that bring people, that very rarely do people just knock on a door and say, boy, I could really use some help with my substance use problems, or, I'm seeking help. It's some major impetus that gets them there. And so that's right behind them and what's bringing them into treatment. So during acute and intoxication withdrawal, it's really important to provide an environment that minimizes opportunity for suicide attempt, just to look around our facilities and around the areas where people are being assessed and being determined for services, just to be aware of that. Frequent safety checks should always be implemented if you have any concern, and patients at risk for suicide should be appropriately monitored and appropriately referred if they are in need of more close observation until they stabilize. And certainly patients who are aggressive when they're intoxicated and are potentially violent, we have to always be aware that that's a possibility with patients. And associated with increased violence are people who are paranoid or hallucinating, who have really severe anxiety or very significant depression as well. So appropriate assistance and referral and placement for safety for those patients is a part of our management in our organizations, and with anytime we have contact with patients who may present with withdrawal and substance use issues. There are also considerations for specific populations and in managing withdrawal. For adolescents, generally most interaction or involvement that we have with adolescents, we don't always see significant major withdrawal with that age group, but what we deal with more than likely is the level of intoxication that they're at. And we know that and that's the case with many drugs of abuse, but certainly with opiate use as well, that more is always better with that, and bulletproof and no concerns for safety is kind of the hallmark of working with adolescents. So that is true with dealing with intoxication withdrawal as well. Certainly the elderly, they have more prolonged withdrawal. Sometimes they have, a lot of health issues, and just the changes in their bodies that occur as aging occurs, their sensitivity to medication, their ability to even get around, to ambulate, and a support system. Sometimes they're very disconnected from their family members, and many of their friends have died, and so there are lots of considerations more in the nature of the way they live. And of course, I mentioned parents with dependent children, and people responsible for the care of their children, and fitting treatment and withdrawal into their life sometimes requires a lot of special support and intervention. Victims of domestic violence and returning to dangerous situations and determining whether or not they need a referral for safe housing or in order to process through withdrawal in the early days of their withdrawal management, and culturally diverse patients, and determining what their thoughts and views and opinions and needs and expectations are for even the language barrier for some people, and their beliefs about medical care and intervention and treatment using all different kinds of therapies. Sometimes it's important to understand what their needs are and what their wishes are. There are assessment tools that are generally used, very, very well known to anybody working in the field, that look at very specific drugs of abuse and withdrawal. The CWA, there is a cocaine assessment making its way back into use with the increased use we've seen in cocaine recently. But the ones that are common in the use of looking at opiates, probably the most common is the COWS, which looks at withdrawal symptoms related to opiates, and the SOWS, which is a subjective opiate withdrawal scale that you give to patients for them to subjectively rate their withdrawal symptoms. And if you're working with people on an outpatient basis, they can report back to you what their withdrawal symptoms are, if they're getting worse, better, what interventions they've used, how it's working, whether are their symptoms increasing or diminishing, and you're able to get a better picture with them about it's the same kind of symptoms that are addressed in the COWS, but the patient does it himself and then reports. Then, of course, there's biochemical markers that we can use and drug testing options, and that is as varied as the programs that are offering withdrawal management. But I think it's really important that we know what we're dealing with, what's in that urine, what substances are there, not just opioids very often, but about multiple other medications that people have used to either try to withdraw themselves or used in combination if they're with opioids and to get a different high, more intense one or longer acting one or whatever it might be. But I think it's good to know what's there. And not always are patients able to be forthcoming with that information initially. And other drug testing, medical drug testing, depending on what symptoms people are presenting with. And just for a quick review of what the symptoms of opioid intoxication look like, and then what the withdrawal looks like as well. So very slow pulse for people under the influence of opioids, low blood pressure, low body temperature, sedation or appearance of sedation, pinpoint pupils, very slowed movements and slurred speech, head nodding, a sense of euphoria, some pain-killing effects, and for many people, a calmness, just a stillness under the influence. Progressing from intoxication into overdose, and we've talked in previous echo sessions about the use of naloxone or Narcan and having it available to people who have substance use disorder with opioids, for family members, for facilities, for physicians' offices, wherever, for first responders, wherever there are people who are going to have first contact or contact with people who are have an opioid use disorder or are prescribed opioids, having Narcan available is really important. Oops, went backwards instead of forwards here. So the opiate withdrawal that we see is on the opposite end of the spectrum that you see in intoxication: very rapid pulse and high blood pressures and increased body temperatures, insomnia, enlarged pupils, abnormal heightened reflexes, sweating, goose flesh, increased respirations and tearing and yawning, runny nose, muscle spasms, abdominal cramps, nausea, vomiting, diarrhea, bone and muscle pain, and increasing anxiety. I heard somebody describe opioid withdrawal one time, that anything that could be wet is wet. Anything that runs will run. That's opioid withdrawal. And what a great description of that I think it is. But for patients who are experiencing opioid withdrawal, this is misery beyond compare. It is, often said that the withdrawal is not life-threatening to people, but for many people, they feel like that's what's happening. They're dying, that this is the worst they have ever felt, or that they would rather be dead than feel this way. And many times people who are experiencing or have experienced withdrawal will avoid at any cost going through withdrawal. And many times that is the initial things that we deal with in management of withdrawal, is the fear that people have of having to deal with this kind of symptoms. So rather than waiting for the cessation of these symptoms, people prefer to either end their torment by using again, and for many people that's what's life-threatening. A period of abstinence followed by a return to usage. Many times the opioid abuser will start where they left off as far as dosage, and then they face the likelihood of overdose and death because they do have a less of a tolerance to the opioids, but they're unaware of that, and this results in death. So management of opioid withdrawal for many, many years was most commonly achieved through the use of clonidine. And for people who were, seeking treatment in medical care, clonidine was used in order to reduce the symptoms of withdrawal about by half is how it worked, and then supportive care otherwise. And it was given, it had to be closely monitored because it affected blood pressures and that sort of thing. And now with the advent of evidence-based practice with the use of methadone and buprenorphine, those medications are commonly now used to achieve a relief of opioid withdrawal, sometimes for just the management of detoxification from opioids, and sometimes it is, in the practice of dealing with opioid use disorders, more of a maintenance kind of medication, maintenance over for people months or years or for a lifetime. So that is what's available as far as of medications. But as people come off of medication, though, medication-assisted therapy, and some people do, stabilize with the medication and then come off of that, they do have post-withdrawal symptoms. And of course, with the use of any medication other than a full opioid, people are going to feel the symptoms of withdrawal. And they can't expect that all of the symptoms will be dissipated by the use of those medications. So we'll talk about other interventions that we can use to help people deal with those symptoms. Other opioid use, management of opioid use withdrawal is certainly impacted by other substances. And many of the patients that we see are also using benzodiazepines or other sedative hypnotics, alcohol. Those two things particularly the most dangerous with opioids because of the effect on the respiratory status, but also cocaine and methamphetamine and other stimulants, hallucinogens and other substances, legal and illegal, and over-the-counter products and prescription drugs. And so there is a significant impact. And if we know what other substances are in the body, we'll know how to deal with the withdrawal. And for instance, alcohol and opioid withdrawal can be managed successfully together, as you often see with opioids and benzodiazepines, that they are managed, the withdrawal is managed concurrently. And with, but in some patients that isn't the, that isn't the standard for everyone, and certainly some patients may come off the opioids, stabilize, and then you address the other drugs of abuse. That is kind of more common practice now. Strategies that we can use to engage people is to really educate them about the withdrawal process, about giving them an idea of what they can expect, what comfort measures to use, that there is, there's many things that they can do to address the symptoms that they're having, a change in diet, a change in their sleep patterns, in just learning how to live under without the drug in their system, and their awareness of what their body's doing and the impact that it has to be without those drugs in their system can be a significant barrier to continued care and continued treatment. So they need to understand what's going to happen to them, what to expect, and what to do in those cases. I think the most important aspect for people who are being managed on an outpatient basis to deal with these symptoms, who have no access to medication-assisted therapy or are coming off MAT in order to achieve complete abstinence, if that is their path, that there has to be support systems in place. For many years in 12-step, your sponsor was the person you called, you went to, and that you utilized in times where you were particularly troubled and particularly concerned about lapsing back into use. And peer support now has come far beyond that history of that sponsor, and there are peer support organizations that are remarkable in the support of opiate use disorder, and that is going to be the person they call, the person who sits with them, who holds their hand, who says, I've been through this, I have this lived experience, I can help you with this. I think that is the most remarkable support that we can offer people, and that has to be hopefully a part of all of the referral source that we have available. And their family too, and educating their family, what to look for, what to watch for as far as increase in symptoms or diminished response to the support that they're being given, and when to bring them back to services, and when to seek additional medical care if it's necessary. But we really want to encourage for people healthy changes in their life and moderation. And it's certainly been the experience for all of us who work with people with a use disorder that moderation is not a word they know very well, and so they get really into exercise or really into lifestyle change and burn out very quickly as a result of it, or go to 6 meetings a day, and there is an assistance that we can give to help them find that moderation in nutrition, in sleep, in other activities that they can be involved in. And last week we heard a wonderful presentation, or the last session, about occupational therapy and what a remarkable support that can be to people where that service is available. We really want to foster a therapeutic alliance with people and utilize motivational enhancement to help them seek out other things in their life that are going to sustain their recovery. And we want to consider alternative approaches to achieving what's normalizing for them. And they may not have any clue what normal feels like physically or emotionally. And a source in treatment is helping them find that. And approaches to use to that is the things that we'll be talking about in the weeks to come. Physical therapy, occupational therapy I mentioned, yoga, acupuncture, music therapy, and very specific pain management approaches. There are many ways to help people find their way into a normal state, whatever that normal state is for them. Referrals and linkages, as people pass through that most severe kind of withdrawal symptoms and they're safe medically and stable, we need to focus on that kind of psychosocial interventions and preparing the patient for those kind of treatment services, and being able to provide a warm handoff and helping them to find their way into other services that are going to be beyond the care that they receive initially for that withdrawal management. So we look at their characteristics and their strengths, but also then what their vulnerabilities are. And that's really going to influence the recommendations that we have for them post-withdrawal. And having a team approach to do that, and many people involved in their care and consulting with each other and working with each other is really important. So if it's a primary care physician or hospital-based program that's referring somebody to treatment services, there should be a really warm handoff there for that person coming into services, regardless of what they are. And preparing a patient to really participate this and letting them know why you're recommending the things that you are and what you hope to help them accomplish, and that you work in through your motivational interviewing techniques, an understanding of what they want and meet them where they're at. Successfully linking them to treatment and those other needed resources is really very important. So I added some things here about how to get some of the free copies of all the TIP products through SAMHSA and the National Clearinghouse for Alcohol and Drug Abuse Information, and the TIPs that can be found online too at samhsa.gov. The TIPs are updated and produced by people with great expertise in the service to patients with substance use disorders, and are updated as we know more, as we learn more about addiction. The ASAM criteria I've mentioned, and a pitch for the ATTC network to be able to go to their website and find all kinds of training and information that's available about substance use disorder and about treatment and about referral to the kind of services that we're talking about. So this is my contact information, and there's questions in the contact or questions that people have. I'd be happy to entertain any of those, or just hear some discussion for people who have had experiences to share here.
Well, Marvis, this is Lisa. We have a number of questions on the chat line. So I'll maybe start with that. I think you generated a lot of interest here, and I do just want to make a comment before I speak to the chat functions and open it up for verbal questions. For all of us in the audience, I think, if you forget everything else that Marvis said, you can always go back and watch the video of this again. But I hope that you won't forget the demeanor that Marvis models for all of us about how to treat people who have the disease of addiction with dignity. And I just really appreciate that, Marvis. It permeates everything you talk about, and I'm always so impressed when I hear you talk because of that. So early on, we got some questions when you were talking about the ASAM criteria, and this will not surprise you. But I think one of the things that people are curious about is I think one of the things you talked about was your own evolution in terms of learning a sort of a new way, a more, if you will, modern way of doing ambulatory detox, and that, we have medications now and we have ambulatory services that challenge some of our old models. And you talked about understanding that, we could safely and humanely detox people in much less restrictive environments. And you sort of described how helpful the ASAM criteria are in helping to objectively assess who can safely and appropriately be managed in what level of service intensity. The questions, though, that came about that, there were a couple of them that had to do with what clinical people should be thinking about and doing when they don't have access to a particular level of care that might be appropriate. And so there was a particular, I think, example of if you don't have 3.2 withdrawal management social detox available, would you recommend that somebody be then placed in an inpatient setting? I think the questions really are about how do you do risk assessment if you don't have in the continuum of care the specific uniquely appropriate setting. How would you think about that? And whoever's questions these were, if I didn't frame that right, and after Marvis answers, please step in.
I think you have to realize what your own resources are. And in a community that doesn't have the availability of the levels of care that are described in the ASAM criteria in many, many places in our state, in many states, in our frontier areas and rural areas. You do what is best. You may learn the criteria, you may understand that there are ways to different than what you have available, but you do the best that you can for a patient. And if the only resource that you have is one physician in your community who has compassion for a patient, will do the best that they can to seek out support from other people who have expertise in the area of addiction, like we're doing here in this ECHO session, that people can learn about withdrawal management, and know what is the least restrictive but safest way to detoxify a patient. And if you feel you assess them, that they're not suicidal, they're not violent, they're willing to take medication, they have a wife at home who's going to support them, or a husband or a partner at home who can monitor their use of the medication. You can teach about withdrawal. They can take them home to their farm 21 miles out of town and help them through the withdrawal management with contact with you, or sometimes it can be a telemedicine kind of support, whatever. I think you have to use whatever resources you have available. And if the only resource that you have is a medical facility, and you have a gut feeling that this person is going to be very sick in their withdrawal, that's where you refer them to, that's what you do. You utilize the best resources that you can, or you refer them to the best resources that are available.
Okay. There was one question that I wasn't sure I understood. It was something about ASAM recommending the least restrictive environment. And I think that this had to do, Marvis, with the least restrictive environment that where safe and effective withdrawal management can be accomplished. I think that what you're emphasizing here.
Right.
Okay.
And I think that that is the recommendation with ASAM, the least restrictive treatment, because that's what patients will embrace. If they are able to have an induction at home, to stay at home, to take care of their children, to continue with their jobs, to come to treatment when they are able to do that on an outpatient basis, that's where you'll engage them. You engage them at whatever level that you can successfully engage them, and you begin there. And if the more restrictive kind of treatment is what they're looking for, and many people do that as well. They want to get out of the lifestyle that they're in and go someplace where they can take a breath. There are, more and more all the time, safer places for them to do that. Halfway houses and sober houses and supportive environments once they're successfully detoxed, that they can live in a supportive, sober environment. So there are more of those, occurring across our nation all the time, I think, and can offer people and that's certainly less restrictive than a residential social detox program. It's certainly much cheaper, to offer.
So I have several. I think we have somebody who's not on mute. You could be sure you're muted if you're not asking questions.
At least not yet.
Thank you. So this was a question that came through. I'm not sure what spawned it, but this person was asking, if you were opening a new facility inpatient, would you allow smoking or not?
Would I?
I think so.
Yeah. Well, I have strong opinions about that, because I'm a recovering nicotine addict myself, and I stopped smoking. I was a 3-pack-a-day smoker, and I have seen the ravages. I'm proud of that, but I've seen the ravages of nicotine for people who are, receiving addiction treatment services, and who continue to smoke. And it impacts their recovery. People are able to stop smoking at the time that they are addressing other drugs of abuse. Can really be a very positive thing. And but for many people, they just can't give up that, at the same time. But I think that the question is, would I allow smoking in a facility? No, I wouldn't. I wouldn't.
I think
that
just a quick follow-up to that.
Yeah.
Yeah,
So,
there have been a couple studies that that actually looked at that, and the chances of successful recovery are not less if you approach nicotine cessation and substance abuse treatment at the same time. So it doesn't actually jeopardize people if you take away cigarettes. So that's an interesting question.
It is.
There's several questions here. I'm trying to think about how to summarize any of these. One question that I think that people have is, should people who are on medication-assisted treatment be in some sort of parallel counseling?
I believe that they definitely need support in some sort of counseling. Not everyone has that available to them, and not everybody is ready for that initially when they are prescribed medication-assisted therapy. But I don't know how you can do one without the other, because it isn't just the medication that makes a difference. It's the medication makes a difference in withdrawal symptoms and in management of physical symptoms, but you look at the chaos involved in people's lives. It isn't just a matter, this illness is, of just the physical symptoms. It embraces all of the other functions that we have as human beings, and we can't fix that by ourselves.
One of my favorite quotes about this is that medication-assisted treatment is a pharmacological platform upon which recovery can begin to be built. And I think one of the things I was struck by today, Marvis, was how well you articulate the sort of wreckage in people's lives that doesn't go away just because they get successfully through withdrawal, and that it requires some rehabilitation and habilitation in many ways that, as you say, not everybody's ready for every phase of treatment at the same time. And so we certainly, I think, see people who start with the psychosocial treatment and then move to medications, or maybe start with MAT and then move to therapy. But I do think I hear you saying you can't do, both are probably necessary in some way. Okay. Do you have suggestions about how to get providers on board for MAT?
I think it involves education. So I don't really have a, I'd like to know that there's a good way to get in it. For me, what I have noticed is that when a physician in a community starts to do this work, the word spreads. It is, a remarkable doctor that I worked with at Heartview has made a lot of impact on other physicians as far as sharing how this works, and how and nurse practitioners and physician assistants. One of the states I work with is Wyoming, and they have invited a consultant to speak at their spring medical conference. First time that there has been a discussion about MAT in their state. So they're invited somebody who works in the trenches and does great work, and is going to do the address. So there's a way to start it, but I think it is a matter of education about how this works, how you can incorporate it and integrate it into your current practice, and to talk with others who are doing the work and finding that it can be done, and it's not as overwhelming as people believe that it is.
I think that's true. I think we have time for maybe one or two other questions. Do you have any recommendations, or do you want to comment on the role of home visits or telehealth home visits, or the use of home health services in the continuum as you're talking about ambulatory withdrawal and support?
I think that would be a remarkable adjunct treatment. I really do. That people are comfortable. That I think when telehealth first started, or communication like this. I mean, look at all of us together today on a Zoom meeting like this. The patient relates really well. I've seen it working and works really well with a professional that they're working with on a media like this. That it's as comfortable them as face-to-face. Home visits, I think you have to really be aware of the safety issues with that, but peer counselors and for many, many years, sponsors did home visit and did work directly with people in their homes and move beyond that. So I think it's a very interesting concept and probably one that would be really embraced by people or others that would not see that suitable at all, but it is not everything is for everyone. So it might be very, very positive experience for some patients.
Agreed. Let me see what else I have missed here. Oh, there's a question that I think we've talked about this several times, and it bears continued discussion because people have different views on this. But the idea of I think that the idea here is not specifically about withdrawal management, but maintenance therapy with MAT, and whether that represents substituting one substance of abuse for another, and whether that is perhaps legitimate or not legitimate. Do you want to speak to that, Marvis?
Yes. The use of buprenorphine and methadone, in my lifetime, I have come to embrace that concept from in my youth as a professional. Only believe that abstinence was possible for people to achieve recovery. That I know that's not true any longer. I've seen it myself. I've seen the incredible recovery that people experience with medication-assisted therapies and with the support that goes along with that. It isn't just about the medication. I mean, when you think about MAT, it is so many people behind that prescription. It is care managers and nurses and physicians and PAs and the person who signs the people in at the clinic and the pharmacist and it's all those people in support of that person's efforts towards recovery. And that is that you don't get that from a dealer. You don't get that from the people that you're using with. It isn't a substitute for it. It gives people their life back. It presents an ability for people to function, to be human again, to feel human again.
Well, I think we've reached the hour, and I think we've hit the majority of questions. I hope we got the gist of most of them. We didn't do the case today, obviously, because we wanted to address the questions that people had. But obviously, Marvis, you struck I think a topic that lots of people really wanted to hear about, and hopefully we'll be able to hear more about this from you going forward. Thank you so very much. Just a reminder to everyone to finish, to fill out your post-test, and you make sure you sign the rosters so that you get credit for having been on the call. Okay? Thank you so much, and we'll see you next time.
Thank you.
Thanks, everyone.
Bye-bye.
Bye.
Would you share those questions back and respond when you're not going to do that? Any that won't answer. Put them on. That's